Okay, so let's get started. So before we get into the content today, I want to address some of the emails that you've been receiving from President Fenves as well as our dean and from me, right? So like President Fenves said, y'all gonna get a 2-week spring break. Congratulations. I wish I was a student again. Class resumes on the 30th, right? And classes, all the classes that are feasibly online will be online. What that means is that my class, this class, it's going to be all online. Then it's going to be the last day I get to see you in person. Are you all sad? A little bit? Okay, that's good. That's what I want to hear. Okay, so what I'm going to do is I'm going to rework the syllabus for us to, yes?
Wait, does this mean the rest of the semester?
Yes, for the rest of the semester. Yes, so all the classes that you have that are probably lecture are probably going to go all online. All the ones that are like the clinical rotations, we go as usual until the sites say, hey, we need to change it up. So everyone is in the interest of getting you to progress, right? Okay, and also be safe at the same time. So, for example, this class we're all going to move online, right? And so I'm going to rework the syllabus so that the timing starts on the 30th. So give me some time. I'll spend some time tomorrow morning to rework it and then just go and look at the updated syllabus. All right? We're going to all move on Zoom. Okay? Any of y'all used Zoom or seen Zoom in action before? Okay, I'll send out instructions on that. It's really fun to use. Seriously, it's really fun if we have to go online, right? And so the guests that I have that work with me will be on Zoom as well. And then when you log on Zoom, I get to see your pretty faces all on there and your names and things like that. So, we'll still see each other.
Do we still have to dress business casual?
Yes, when you have guests, because I don't want any funny T-shirts. Okay? Right? Yeah. So think of it as practicing for your video interviews. Okay? There's a reason why we do these things in class, okay? So I'm trying to get you acclimated to those things. I don't do it just for my own fun, although it's kind of funny. All right. Attendance will still I'll keep attendance online. The timing is as usual, like in this class, right? We start at 11, we have a break, we start at 12:05, we end at 12:50. So what that also means is the people who are helping me with the timing, I still need help. So to keep with the timing, and the folks who are helping me with the attendance in terms of the name tags, I would need you to take screenshots and send it to me. It's a very easy screenshot, okay? Right? Is everything okay?
Just a little shocked.
A little shocked that we're going online for those semesters?
Like really intense online.
Yeah. I think the university is just playing it safe, and so I'm doing what the president and Dean Seifert wants me to do. Yes?
Oh, no, sorry.
Okay. There was a reaction to going online?
Yeah.
You get a whole semester. Yes.
So what is that basically like simulations and stuff?
Your faculty will send you all that stuff. Okay. We're all working it out. This is our first time with Corona, so we're just working it, okay? Your mock interview assignments could be done on the phone or online. It doesn't have to be in person. Okay.
For the insight sheets that go with that mock interview assignment, is the best way for them to send it to us?
Yeah, send it to us.
Scan it or to type it? Or?
You could send it to them, and then they could write on it and scan it and send it back, or take a picture and send it back. Okay. And then also with the insight sheet, we have an insight sheet for every class. I'm going to expect that to be submitted 5 minutes by 1 p.m. Okay, so y'all get an extra 5-10 minutes to do. So I will upload it on Canvas for y'all, and all you gotta do is just type it in and just send. Okay. Any questions on that? All right. So just stay calm and just follow reasonable precautions. For example, Tito's Kavaka is not going to help you as hand sanitizer, so don't do that. Right? Cocaine is not going to help either. Right? So take the precautions that we said to you through the university. Yeah, I know. So instead, do the things that Dean Steinberg sent to you in email, right? Avoid personal contact, mass gatherings possible, practice social distancing, or what I call social or anti-social distance, 3 feet, avoid sharing food or drinks, wash hands, right? For at least 20 seconds, keep your hands away from nose, mouth, eyes, cough, sneeze, and elbow, and use verbal forms for greeting in lieu of handshake. So for today, use verbal forms of greeting. Any questions about that? Okay, so vodka's not good, cocaine's not good, these things are great. Okay? All right. So let's get to the fun stuff that we're going to do today, and I have 2 wonderful guests with us, Danica Meyer and Amy McCarthy, who's going to work with us on clinical case interviews, right? And this is my favorite part, one of my favorite parts of this class, not because I get to sit back there and just enjoy and watch, but they bring a very sought after content that I can tell you that you can't find on books. There's only one video that we've been able to find that's relating to clinical case interviews. So I'm just really glad to have them here to help us. And I will let them, so at this point I'm just going to hand it over to them and they're going to introduce themselves and go from there.
Good morning. How are you guys? Good? Okay, awesome. Normally I would take it personally that none of you are sitting in the front seat, but Dean told me that it's okay because of the social distancing aspect of coronavirus, that it's all right that you guys are 2 or 3 rows back. I'm going to give Amy an opportunity to introduce herself in a little bit, and you guys have to excuse me. I do this for a living all the time, but since she's my friend, I'm kind of nervous. So this is the first time that she's ever seen me present, so this is a really unique opportunity for you. And for one thing, I teach all the time about clinical case scenarios. I do onboarding and staffing for pediatric ICU nurses, and Amy will get to speak to you about this topic in particular because she's a nurse manager and does the majority of hiring for her area. So we're going to go ahead and get started. This is me. I'm going to tell you a little bit about why I am qualified to speak to you today. I was a graduate of the UT School of Nursing back in 2011, and I am a die-hard Longhorn. I was just telling Amy I can't wait to go and relive my college days with her. We're going to walk around the 40 acres. But we're not dressed this way back then, so we'll probably change into some yoga pants or something. By the way, I love that Dean Wynn makes you guys dress up. I think that's really neat. I know it's probably not so fun for you all, but it will prepare you for a lot of the things that you're going to be doing out in the real world, like meetings and interviews and that kind of stuff. So, I was a member of the UT Student Nurses Association. I was a co-founder of something called Students Making Impacts Through Love and Empathy. Is anyone here a member by any chance, or have you heard of it? No? That's totally okay. I think they're not, it's like only 200 people or something. Camp Texas Counselor, any Camp Texas counselors in here? And I was a St. David's volunteer. So I love UT. This place opened a lot of opportunities for me, and I just think it's the best place in the world, and I'm super honored to be here with you today. And also, please feel lucky that the nursing school did not look like it did when I came here. So, I don't know if you guys have you seen pictures of it before? Oh yeah, it's here. You were here? Oh wow. Okay. Yeah. Oh yeah, and then the walls were kind of dark. Like if you licked them, you could get lead poisoning. Yeah, this place was so beautiful, and I'm very jealous to get to be here. So, what my experience is now, I'm what's called a clinical practice and advanced education specialist too, which is really just a fancy name for a clinical nurse educator. So, the nurse educators that you all interact with are academic. I'm actually a nurse educator for a clinical facility. So. I am the nurse educator for the PICU, Active Children's Healthcare System. I love it. It's the only place I've ever worked. Before that, I was a PICU staff RN for about 3 years. So I've been a nurse for almost 9 years now, and I love it. Everybody I know is a nurse. I come from a family of nurses. My sister actually also works at Cook Children's. I have speaking experience at the local, state, and national level, so I've spoken at the Society of Pediatric Nurses, the Children's Hospital Association of Texas Conference, AUNL, which is the American Organization for Nursing Leadership, and I mainly focus on critical care, nursing professional development, which is what the I guess, official title for what the role I do is called. Leadership and onboarding. So I love working with new nurses especially. That's my favorite thing to do just because I remember it still feels a little raw to me to be a new nurse even though I've been doing this for so long. I think that is such a formative time in somebody's career is that very initial time you enter the nursing workforce. I have specialty certifications in pediatrics, nursing professional development, and I have a master's degree in nursing education. So I'm also a PALS instructor, which is, I'd just like to put that on there because that's my favorite thing to do, getting to interact with people in small groups. So with that being said, that's kind of a lot. Let's start a conversation. So I know to make this meaningful for you, I really wanted to get an idea of why you were interested. Well, I guess you don't really have a choice, you have to be in the class, but I want this time to be meaningful for you and useful. And I'm a pretty informal lecturer, so I love conversation. It doesn't make sense for me to be a sage on the stage. This is kind of what we call that. I'd rather be a guide on the side. So you help me make this time good for you. Do you guys have any comments about what makes you nervous about case scenarios, why you might be interested in getting more information about this topic? Yes.
Yeah, sure.
What's your name?
Tyler.
Tyler, okay.
I'm actually doing a podcast with you guys.
Oh yeah, we're gonna talk to you guys about that later.
So it's like Dean was saying, there's not a lot of information published about how to answer these questions.
Sure.
And so in clinical, when the professor asks you a question about what would you do, that kind of stuff, it's a different kind of thinking thought process versus trying to answer what you think an interviewer or a professional would want you to say, and how they would want you to go about it versus how you feel is an appropriate way to go about it.
Perfect. I love that. Hopefully we'll get to touch on that and you guys will have to practice. Of course.
Yeah, I guess kind of going off of that, kind of just like what's too much to say, like what's too little.
I love that. Perfect. We'll talk about that too. And what was your name?
Khadijah.
Khadijah, okay.
I kind of wanted to know, like when you're given information on a situation, do you just take that information and answer, or do you like create alternative scenarios or like speak more on like if this happened then I would, or does that make sense?
Yeah, that can be very tricky for sure. Anything else? No? Okay, so we're gonna move on. So, a couple of comments on the questions that you guys asked. For one thing, I think case scenarios get a really bad rap. There's a lot of anxiety around it because there's no real formula to do that. And I will say that the strategies I'm going to give you are they're not new to nursing. You probably have already heard of them. I'm just packaging them up to you so that you can take them and actually apply it to your behavioral case scenarios. So all of these terms you're probably going to know already, but I'm going to show you how to use them so that you can implement that in a case scenario, if that makes sense. And I also want to reaffirm to you that you guys are new nurses. Nobody's expecting you to come into these case scenarios and know exactly what to do. And nursing school really prepares you to make sure that you're not harming your patient and you're keeping your patient safe, just like the NCLEX, right? But nobody's expecting you to have the training, the knowledge to answer this like an experienced nurse would. So keep that in mind. A lot of the times, these case scenarios are really to assess whether you know how to critically think, have clinical judgment, and also know how to communicate with other people and work as a team. So kind of goes along with what you were talking about. How would somebody like a nurse manager want you to answer those questions? Those are real assessments they're actually making, not if you have the clinical knowledge or the training, because you obviously don't have that, right? Okay, so here's what you can expect from me. So we're going to learn the structure of a couple of different types of scenarios, the ones that Tyler was kind of talking about. Learn elements of information gathering and answering a clinical scenario, opportunities to practice. So I know that I heard that you guys get these really cool folios, that's incentive, but also real life experience. And I feel like Amy and I are pretty approachable people. This is a really safe time to do that, and you're in a room with your peers. So if you want to volunteer, keep that in your mind. We're really, really nice. I feel like I have an affable face. So very, very not scary. So expectations of you. If at any point you have a question for me, this is your opportunity to discuss as a group. Participate, ask me questions, ask Amy questions when we get to that point, all that kind of stuff. So just try to stay engaged. If you need a break, I know you guys got a break at some point. Somebody will tell me, right? I don't know who that is, but okay. Here's an additional note for you. So this is going to be a methodical and strategic way to approach clinical scenarios. but it's also not going to replace any good clinical judgment or critical thinking that you've already been training for. So I know that you guys are in your J2 and S1 semester, is that correct? Most of you are. So if you're not taking that seriously now, it's not going to help you by the time you get to an interview. So if you don't have good clinical judgment or you don't know how to critically think, by the time you get this, none of my strategies are going to be of help to you. So make sure that you're really, really studying all the information that you're getting in clinical, in classes, especially about the specific patient populations you're interested in interviewing for, because likely that's going to be a component of your clinical scenarios, right? So if you don't know what normal vital signs are for adults, it's probably not going to help you later. So make sure that you're doing that right now. Okay, so why case scenarios? Critical thinking, clinical judgment, prioritization, communication, and skills are the number one reason that most people will use case scenarios to delineate which interviewees are more qualified than others, right? So a lot of those terms sound very similar. So can anyone in their own words tell me what the difference is between critical thinking and clinical judgment? Because they kind of sound like the same thing. Am I wrong? They sound like the same thing, right? Okay. So can anyone take a stab at it? Julie.
So I would say that clinical judgment encompasses critical thinking, but in clinical judgment, it's more situational based off your patient, what's probably best for your patient, and yeah.
No, that's perfect. So critical thinking is not unique to nursing, right? You need critical thinking in life, in any job. It's not just nursing. So critical thinking is just your ability to problem solve, right? And Julie's correct. Clinical judgment encompasses critical thinking. Clinical judgment is really your ability to assess a situation, have lots of information thrown at you, and you know what to do with that information. So interviewers are really looking at, if I throw all this information at this person, are they going to freak out? Are they going to be able to really take in every information and delineate what's a priority in this situation? Do I know what to do with this piece of information? This isn't relevant right now, but I'm going to focus on this to keep my patient safe. So making sure that you know the difference between the two and know how to express both, that you know how to problem solve and think, right? But also know what to do with that information is a big piece. You guys are trained right now to know just information. The biggest piece between now and the end of graduation is knowing what to do with that information. So making sure you practice how to do that. Because really, in case scenarios and behavioral interviews, you want to have those real life experiences that you can apply in those interviews. Any questions about that? Okay. So tackling case scenarios, what I'm going to go over now is kind of the meat of the presentation. So important things to remember. Are you answering the question? I think Kadeja, right? She said, how do I know how much is too much, and how do I know that if I'm talking too much? Just try to focus on what your interviewer is asking you. And if you're not really sure, this is where information gathering will help you identify what's deficient, if that makes sense. Because sometimes it sounds like, what do you do? And you're like, I don't know. So this will kind of give you a strategic and systematic approach to figure out what are they really asking of me. Patient safety. So you all know and probably identify with this, right? The NCLEX. While that's correct, it's not the most correct. So really, when you're thinking about those NCLEX questions you guys are studying for, it's really trying to identify, does this person know what is the most safe thing to do right now? And you guys know why calling the physician isn't the right answer most of the time, right? Why is that? Huh?
It's not like the first thing you do.
It could be, but that's not the only thing you would do. If somebody tells me, I'm going to call the doctor, it kind of makes me think, okay, if Amy fell out right now, I would just call the doctor. Good luck, Amy. That's not what you want to do, right? What would I do if Amy fell out? I would probably go in there, check her pulse, making sure she was okay. That's really what I want to hear. I'd probably call the doctor at the same time, but what's most important is that I go over there and make sure she's safe. Does that make sense? So patient safety is the number one thing. If anything, you don't need good clinical judgment to keep your patient safe. I mean, you do. But, you're all trained to do that right now in nursing school. You all know basic BLS, all that kind of stuff. Take notes. So if you have an opportunity to take notes in the interview during a case scenario, most of the time in my experience, this is a very auditory process. So it's not typical that people will hand you a piece of paper. It could be, But more likely than not, you're just hearing this information. And we are very tactile, kinesthetic. We use all 5 senses in our profession, right? So if I'm just hearing it, my job as the interviewer is to make sure that I can use all of my senses, take that auditory component, and make it into a visual and tactile. So if you have to close your eyes and take notes, you have to do what you have to do, right? Okay. And then nursing values. And what I mean by this is not necessarily what your normal parameters for labs are. I mean making sure that you are implementing components of beneficence, maleficence, ethics, all of that in your interview. So when you're providing an answer, making sure that you're still hitting all of those things. Any questions about that? Okay. So now preparing for an interview. Oh, okay. So preparing for an interview, making sure that you practice, knowing the normal values, like I said, and then researching the organization. Is that right, Amy? You want to know what type of organization you're interviewing for. And what I mean by that is that you look up the mission and values of the organization, you learn a little bit about the unit that you're interviewing for, how many bed spaces there are, you know, what the normal structure of the place is, opportunities to get involved. A lot of those things I hear in questions, but it's so much more impactful if I know that somebody who's applying and interviewing already has that information, because it shows that they really want to work there. So, and it's also good for you because then you've identified if this is a culture and place you really want to work for. Okay. So that's all the fluffy stuff. This is the 5-step systematic approach, and we're going to go over these one by one. So information gathering, prioritization, intervention, and defaulting to action, communication, reassessing, and evaluating. So don't worry about it if you don't get all of it right now. We're going to go over each one. Okay, so information gathering. When I talk about information gathering, it's really, like I said, trying to make this auditory experience as visual and as kinesthetic as possible, right? So the couple things that you want to ask for are environment and resources. A lot of the times you're going to be presented with a clinical scenario. You're going to ask, what do I do next, right? But you might not know what's available to you in this clinical scenario. So you're going to want to ask about what's available to me right now, what does the unit look like, what is in the room for me to use. And then initial impression, what is my across the room assessment and what do those vital signs look like? So if I walk into the room, what is my patient interacting with me? Are they responsive? What's their color like? So there are things that you can assess from a scenario without even having to do a tactile assessment or an auditory assessment, right? I can just look at the patient as soon as I walk into the room. And then you all know what A, B, C, D, and E stand for, right? You know at least A, B, C. Does anyone know what D stands for? And E? Perfect. Sample, you all know what sample is? No? Okay, so sample, we're going to teach you that right now. It's a very quick history-taking assessment. So S is signs and symptoms. A is allergies. M is medications. Don't worry, it's on the next slide, so don't worry about writing all this down. P is past medical history. L is last meal, and E is events. So events leading up to whatever happened that brought them in today. Let's see, head-to-toe assessment versus a focused assessment. So this one is a really big one because sometimes people will ask you for a head-to-toe assessment and that's it. Or they'll ask you just for the focused assessment. Or they might ask you for both. So if I'm asking you for both, what do you think I want to do first? Focused and then head into your head-to-toe, right? And then diagnostics and lab values. A lot of the times the diagnostics, it's okay to not know it. Just because as a new graduate, you might not always know what to anticipate to ask for as far as diagnostics, right? Okay, so here's that if you missed it. I'm going to give you about 15 seconds to write that out if you need. Does anyone have any questions so far while we're going over that? So information gathering is really important to give you a good picture of what you're going to be answering in the scenario, right? So there are times in which your ability to gather information is also assessed. So this is a really great way, if you got all of those points down, knowing where to start. So it kind of starts from my environment, my patient, and then more focused as you go along. So this is a really great way to study all those different points and find out what's deficient for you. Yes, Kasia?
So if you're given information, and the first step is information gathering, so you're asking those questions like, what resources do I have? Is that like a hypothetical? Like, or am I expecting an answer where they'll tell me like, oh, you have sectioning available and this and that, or is it just like word vomiting and saying like, this is what I'm looking for?
It's more like asking them.
Okay.
So if you're not sure what they're asking you, this is a great way to figure out what is available to you, because sometimes that's not what they're looking for. It gives you clarity on what they really know, because sometimes they don't even know. Does that make sense? Like, I didn't even, that's not what I'm asking.
Oh.
You know what I mean?
Yeah.
So sometimes it goes back to, if it's what do you do next, then you're trying to figure out what resources do I have available, and then not giving you any information about the patient or enough information about the patient. That's a great opportunity to make sure that you're getting all of the information that you can possibly get. And sometimes they'll look at you like, well, that's not really important right now. Then you can go back and say and think to yourself, well, okay, what are they really asking me? Because sometimes they're just asking you just a safety question, you know? And it could be just that you know to ask those questions. Does that make sense? Does that kind of answer your question?
A little bit. I'm just wondering, like, is that something I actually ask them? Like, do I have this in the room, or is it like something I'm just thinking to myself?
It depends. It depends. So it depends on the question. So it'll probably be more clear to you once we can apply this,
Okay.
if that makes sense.
Yeah.
And if it still doesn't answer your question, then ask again, and maybe I can provide a little bit more clarity after we talk about that. Okay? Good question. Okay. Oh, so for example, you might be asked to conduct a head-to-toe focus assessment, and they're really just trying to figure out, do you know how to do an assessment, and go through all the different components of what that entails. And sometimes they're just trying to figure out, do you know how to do a focus assessment? Does this person know what's most important right now to look at? Okay, in information gathering, you're trying to identify what's deficient right now. So if you're still unsure of what to do, and you've only been given parts of an assessment or just little bits of information, this is your opportunity to pull this list out and knock out, okay, I think I've gotten information about this, gathered information about this, and I still don't know this and this and this, and I need those components to take care of the patient technically. And that's a really great systematic way to figure out if you still need to ask more questions. Because that is a component of it. This is a very interactive experience, right? It's not a test where you're asked a question, you give an answer back. This is a lot of the times a dialogue for the most part. Okay, so prioritization. This is common in questions that ask you, what would you do first, and tell me how you would proceed. So what set of interventions come first and why? And if you're asked about this, you definitely want to think A, B, C, D, and E, and what are the glaring safety concerns in this scenario. So it goes back to the example I gave you about Amy falling out. I want to make sure that Amy is safe. So that's the number one thing I want to do. Intervention and default to action. So this is also applicable in what would you do and what would you do next. Always assume that no one is available to help you initially, right? Is that your experience in most of your sims? It's just you in the room, you don't have anybody to help you. What would you do in this situation right now? And what can be delegated? So whenever an interviewer is asking you a question about what would you do, I want to know that you're going to default to action. Calling a physician is not necessarily defaulting to action, it's actually delegating that action to someone else. So now calling a charge nurse is also delegating an action to someone else. It's also consulting with them, but I want to know that you know what to do to keep your patient safe. So that's a very important component of answering a question. Communication, so common in questions that ask who would you notify, and also can be a component of what would you do next. So you all know what SBAR is, but really in interviews, I want to know that you know how to make a recommendation. And if you don't know, it's okay to say, I think I would recommend this, but to keep my patient safe, so blah, 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 blah. That you at least attempt a recommendation, because most of the time we see with new nurses, they stop at SBAR. are. So make sure that you hit the recommendation component. Focus also on being concise. So what does the receiver need to know right now to help you? Oftentimes when we experience an SBAR, it feels kind of like you're reading the whole report sheet, right? And you're giving them the entire history. Just give enough information so whoever you're notifying has enough information to make sure that this is a big deal. So situation could be, I'm taking care of this and this patient. Here's a little bit of history about them. You might remember that they're here for this and admitted for this. I walked into the room. This is what I saw. It didn't look great. They were decompensating. They were desaturating. These are the things that I've tried. Can you please get me this type of order? It can be as short as that. It doesn't have to be very lengthy, right? And then reassessment and evaluation. So what would you evaluate and what indicators and outcomes are you looking for? So identification, intervening, and evaluation are big components of communicating in a case scenario what you would do. If they don't ask you that, it's always good to just kind of throw it in there to know that you will circle back on your patient. Does that make sense? Okay, so variations in scenarios. I think Kadeja, either Courtney, Tyler, or Kadeja asked this. So variations in scenarios, it's hard to tell because there are so many different ways that people can ask about a case scenario, right? Sometimes you have that very straightforward. Here's this information, this is all you need to know, I just want to know about this part. So that's a more straightforward scenario. Then there's unfolding case scenario, and I think this is what you were talking about. How much do I answer? Are they going to ask me more questions about this? And it's hard to tell in the very beginning. Sometimes you end up answering their questions in an unfolding case scenario because you don't know if it's coming. Most of the time that's very clear. So right now, you walk in on your patient, nobody's available to you yet, what would you do? You answer that question, and then you go on and say, the parents now arrived. What history questions do you ask? Does that make sense? So that's what I consider an unfolding case scenario. The third type of scenario that I've seen is kind of like a choose your own adventure. So depending on how you answer the first question determines what kinds of questions they'll ask you later on. So very similar to what you all experience in simulation. So if you do this one thing in simulation, a lot of the times the person who's running the simulation can push a button and determine how the patient will respond depending on what you do. So most of the time in those questions, they'll be very direct about what they want from you. So I wouldn't worry too much. Just focus on answering the question. Any questions about that? Okay, now it's time to practice. I need 3 volunteers, actually. Does anyone want to volunteer? Okay, Julie. Courtney. All right, Tyler. It's okay, this side of the room I don't think is okay. Right? Okay, so I'm going to give Amy an opportunity to introduce herself while I set up the tables.
Thanks. Hey guys, I'm so happy to be here with all of y'all today. And to hear my friend Donna speak. So a little bit about myself. I'm excited to be on campus with y'all. I am very passionate about nursing. I have been from the very beginning of my career. I've been a nurse for 7 years. My wheelhouse is really women's and infants. I started my journey in mother-baby as a nursery nurse, then I learned postpartum along the way, and then finally merged them both together into a mom-baby component. And then was always very interested in leadership. Wanted to be a leader from the very beginning. I loved being able to help nurses and work with them to really achieve what we all got into nursing to do is to help patients and to really get better outcomes and to help patients leave the hospital healthier and in a better state than when they started. And so a little bit about myself, I graduated from UT Arlington School of Nursing program in 2012. I'm currently now a student in a DNP program at George Washington University in Washington, D.C. With my focus on executive leadership. And then also where we met was when we did our master's degree together. She did in education, but I did in nursing administration. So again, my focus has always been on leadership. And so I've been in a leader role for the last probably 5 years. And currently I work as the maternal fetal medicine specialty clinic manager at Parkland Hospital in Dallas, Texas. Like Donica, I've spoken a lot both at the local, state, and national levels and have really focused on leadership and then also women's and infants' health and also also just on the practice of being innovative. I think there's a lot of space in nursing for us to try out new ideas, and so I'm always encouraging nurses to take those ideas, because a lot of you come into the clinical space with so many great, new, innovative thinking that can be spread to nurses. And you're going to have barriers to that, but I really encourage all of you to bring those ideas out into the open and talk about them, because that's what's going to bring the profession forward. And I do so much speaking about that. I'm very passionate about that, if you can't tell. It's really helped me to pursue a lot of work. I currently serve as a secretary on the board of directors of the Texas Nurses Association, which I encourage all of you to join once you graduate from UT. It's a great organization. It really helps to advocate for nurses across the state of Texas. We really try to empower all of you to use your voices within the clinical setting or out in the communities. We offer a lot of various resources for that. We're going to talk a little bit about our podcast that we're starting through the Texas Nurses Association to speak with nurses across the state and to talk about your stories, not just at the executive level, but also at the clinical level. Because one of the things that I found as I've traveled is that nurses, regardless of how many years of experience you have, are doing some incredible things. Even I was just recently in Austin about 2 weeks ago at the Texas Student Nurses Association conference, and I heard some incredible ideas coming from students who are in exactly the same place that you are, kind of talking through ideas, doing things in their community. And I really encourage all of you to continue that as you go out in your careers. A lot of times you get into your first nursing job and you're like, okay, I have a job, I have a paycheck, this is great. But that idea, those ideas, that mode of thinking needs to continue, because again, that's what's really going to help our patients in the long run. I can't tell you how many times I have conversations with nurses who are 2 years out of school, or even nurses within their interviews, who talk about a lot of the ideas that they thought about in nursing school, a lot of things that they've seen in their clinical components. And when we talk about interviewing, that's what really gets my attention, is when I have nurses that come to the table and who are talking about, hey, I think that this would be a really great idea. I've been thinking a lot about getting into women's and infants, and this is what I want to do in the labor and delivery space or in the mother-baby unit. Those are the ideas that I want to hear, because when I look at you and I can hear about your clinical experience, and I can hear about everything that you learned, but I also am looking at your critical thinking. Like Donica said, I can't teach critical thinking. I can teach you skills, but I can't teach you how to critical think. I can't teach you how to be a leader. A lot of those things come just through your own experiences. And so, when I see that in the interview, it really stands out. So I encourage y'all to think about that and to come prepared to your interviews to talk about those ideas, because that's what excites me, because I want to bring nurses to the table who are going to do really incredible things within the space and to really help, our communities and our, profession across the board, because that's a huge goal of mine, is to really kind of transform nursing just at the state level and at the national level as well. Again, I've been a nurse for 7 years. I actually started in marketing and PR and communications and did a little bit of graphic design and just overall communications work. And so it's been really neat now as a nurse to be able to meld both of those fields together. I serve on several boards of directors, both at a state and national level, where I get to use that experience and help to create communications plans to help get the message of nursing leaders, getting nurses to serve on boards across the community, not just with the hospitals. And again, sharing those types of ideas with people across the nation. And then my certifications are in nurse executive leadership and maternal and newborn nursing. But again, so excited to be here with y'all today and to speak a little bit about the interviewing process.
She doesn't need as much coffee as
I don't. I'm very energetic.
Okay.
So, Donica,
Yes.
Jason's going to be Jason, you're our 5-minute warning person, right? For the break?
No,
Who was it? Julie, you are? So, Jason, can you do it if Julie's up there?
Yeah.
Okay, all right.
Great job, Jason. Okay, so a couple of ground rules before we get started, especially for Julie, Courtney, and Tyler. This is a supportive environment. We're all learning, right? No judgment at all, because I like the sacrificial lambs. So make sure that you're kind. Don't worry, it's not scary. It's not. If you are not at the front of the room, please actively participate still. These are really great examples, and really, a lot of these are just pal scenarios that we have modified into our own interviews, so nothing unique. See if you can think along. Start thinking about the questions you would ask whenever we're done, because we will get an opportunity to debrief all 3 of these. In the very first scenario, we'll actually get to do together as a group before these 3 people come up and do it together. Is that okay? Oh yeah, no. That's not how we learn, Sometimes if you're freaked out, you're not going to learn anything. So we're going to do it together, and so you can kind of see some tips and tricks, and I'm going to invite Amy to kind of comment on things that might be important for her as a manager here. So yeah, individual debrief followed by a group debrief so you guys can talk about how nervous you were for Julie and Courtney and Tyler. So yeah, we'll get to do that. So guided practice, there's an intervention-based scenario that I have in here, a prioritization-based scenario, and then an assessment-based scenario. So it's going to get progressively harder. I don't know if I should have told you that, because one of you is going to have to go last. But we'll figure it out as we go. Okay? Okay, so first, let's talk about this one before we invite those three to come up here. And do we go till 12:30?
Well, we have a break at 11:50.
Okay.
And then we
Just making sure.
come back at 12:05.
Okay, and then do
12:50.
12:50. Oh,
Yeah.
wow.
We have to be out of here by 12:50 for the next class.
Okay, we won't take, I don't think we'll take till 12:50, but.
We're also in the next class, so it's fine.
Oh, okay.
Well, the other thing, plus I want to take some pictures and then we have to go to our next thing.
Got it, okay. All right, so you are on, and don't worry, we're using pediatrics, but I'm not assessing whether you know pediatrics or not, because I know your clinicals are very short in pediatrics, right? Some of you don't want to be pediatrics. I can't imagine why. But yeah, that's not what we're assessing. So don't worry about the clinical information. We're just going to coach you on how to answer the question, okay? And yeah, because Amy's probably not going to answer these. You are on an inpatient pediatric unit. You're asked to assess a 5-month-old who is admitted for a history of high fever and lethargy that has lasted about 24 hours. She has not eaten well. So for pre-interview work, what do you think would be very important for you to prepare for before you even walk into this? You know you're going to be interviewing at a pediatric hospital. Name off some things that you would make sure to study before you go.
Like the normal pediatric practice.
Yeah, yeah. What if you were going for like a hematology oncology unit in a pediatric facility? Okay, what else?
Normal growth and development for the different stages of kids.
Yeah, perfect. What else?
So common like illnesses that are seen in that time of year or
That.
in that population.
Absolutely. Especially with certain specific diagnosis for maybe the unit that you're even interviewing for. So if you know you're going for a respiratory floor, try to see what types of diagnoses you can look up that's unique to that area. Corley? Did I say that right?
Yeah.
Okay.
Knowing possibly for this in particular normal like intake and output for weight and age readiness.
Perfect. And you know that pediatrics is weight-based, so it's important to throw in that component, right? So you kind of answered what would be helpful to prepare in this scenario. So information gathering. I didn't give you very much information. So how would you systematically ask about how to take care of this patient? Because I'm probably going to ask you, what would you do next? What would you do first? Lexi.
Ask what resources you have available.
Yeah, so everything that's normal to an inpatient unit. You're not in the emergency department. You're probably in the hospital setting, right? So suction, oxygen, all that is available to you. You have support staff as well that you can call for certain resources. Okay, what else?
Are the parents there as well, or is it just the baby?
Right now it's,
Just
well, let's say the parents are there. So what other information could you also gather?
maybe whether there's a sibling at home, a school-age sibling, when the last meeting was.
Yeah.
And how much or how long.
Yeah, so that's where sample can come into play, right? So to keep yourself organized, I encourage you to do that systematically. So are there signs and symptoms? Are they allergic to anything? What medications have they already received? What's their history like? When did they last eat something? If there were siblings, if they've been exposed to anything. So that's a huge component of this, is making sure that you're doing everything in an organized way so you can keep track of what you've asked. Because in this situation, you're probably so overwhelmed that you're just getting asked a question that it's hard to remember what you have asked and what you haven't. So that's a really important component of this. And actually, these techniques are going to help you in just regular nursing too. So, okay. I actually have listed all of these out for you. So you have an ABCDE assessment, a head-to-toe assessment. Yes, Julie?
Oh, no, no.
Oh, is that 5 minutes? Okay, thank you. Okay, so priority. What's the priority for this patient?
I think you can put it to the especially if they have a history of high fever.
sure. For sure. What do you want to ask about? Well, you guys have already asked about sample, right? What else can you ask? Yeah. So give you a set of vitals, and let's say their respiratory rate, they're a little tachypnic. Their sats are like 85, 86. Their blood pressure is within normal limits. Their heart rate is tachycardic. So how does that change things for you? What else do you want to ask about?
Maybe the physical assessment that you can do in regards to dehydration.
Yeah.
Mucous membrane and salts.
Focus assessment.
If they're currently on any oxygen.
Yeah, for sure. Hannah.
I would be asking about doing, like, what do I see retractions with, if they're breathing, if their sats are that low?
Yes. So I would actually go to that first, even before those other things. So A, B, C, D, E, right? After I get those initial set of vitals, definitely your airway, breathing, work of breathing is within breathing, right? And then circulation, what that's like. Are they talking to me? So I actually did put this in order of how you should ask. So initial impression, what do they look like across the room? Priorities A, B, C, D, E, you guys learned that, right? And then you can go into history, so it's perfect. So,
I think it's important to note too that you are doing a physical assessment because, you know, in the world of technology, we have so many monitors, especially within pediatrics and infants, that you're not just relying on that or telling me that, yeah, well, I'd look at the monitor and see that this was the, you know, the blood pressure and everything. Actually physically looking at your patient, because sometimes those monitors will go off, but your patient is doing just fine.
Yeah.
So.
sure. Okay. So now that you have gathered a little bit of information, I've given you your initial impressions, your ABCDE assessment, and I said your work of breath, they're retracting a little bit. Their circulation, their pulses are 2s. Their cap refill is maybe a 3, less than 3, right? Let's see, it's disability, they're crying, but weakly crying because they're working so hard. And exposure, their temp, let's say, is a 39. How does that change things for you? You're looking a little nervous. So what's your priority now that you have that information? What sounds like the scariest part to you as a new nurse? Temperature.
I would say the red wavy retractions.
Yeah. Your retractions, right? Because see how much farther B is earlier in that acronym than E? Because E is exposure, and that's where temperature falls, right? So airway is the most important, breathing, your work of breathing. So if that's the most important, you can technically take care of their temperature anytime. You're probably going to delegate it to somebody. But is it an emergency right now? No, because what could happen if I try to address the temperature first, but leave the work of breathing, they're tachypnic, their respirations are, tachypnic and respirations are probably the same thing, but their sats are a little low. It's not great. It's not terrible yet. But if I try and walk over to the Omnicell to get some Tylenol and it takes me, 20 minutes between getting up there, scanning it, blah, 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 and I come back, and that patient has been laboring for that long, what do you think is eventually going to happen? They're going to get tired, and then they're not going to breathe anymore, right? So, yes, make sure that you're trying to address those things in that order. So that's going to help you prioritize within that realm. A, B, C, D, E, literally in that order. So if you can categorize pieces of your assessment in those things, then address whatever's earliest in that acronym. So if there's something wrong with their airway, like they're grunting, or it sounds like they're stridorous, or something's not right with their airway, or it seems like they're not breathing, make sure you address those things first. And of course, circulation, and then disability. So if you hear something about their level of consciousness, that comes before temperature, right? Okay. Does that make sense? Okay. Okay, so now you guys have said, I'm worried about their breathing. We've talked about, you prioritize that now. What's your default to action at this point? Yes. So I'm going to want to hear, I'm going to give this patient oxygen. I'm probably going to notify somebody at some point because they're working so hard. But him oxygen, so I've applied that oxygen. You probably communicated that. So if you were, likely there's a standard of order that you can apply oxygen to most patients, right? But what if you did have to call somebody? How would you do that? How would you put that in an SR? Don't be shy. Just ask. Yes, Brittany.
You would say that you have on both patient and you for high fever and allergy, and we know the patient is currently having retractions and in a low O2 sat, so you need a limit for oxygen.
That's perfect. That's great. Concise, right? I kind of know a little bit about the patient. They're retracting. Okay, yeah, that sounds pretty serious right now. You need oxygen? Great. You get oxygen. Perfect. Now, what would you reassess and evaluate? Perfect. Now, an interviewer could also throw in a component like, it didn't work. What would you do now? And now they look worse. So that's where the unfolding, you know what I mean? So they can drag that out as long as possible. So just know that if you have to circle back to these information gathering pieces, where you have to hit A, B, C, D, E again, you know, you probably already hit sample the first time, but then head to toe prioritization. So make sure that that's the systematic formula that you're using. Okay?
So
Yes.
I know where like you were saying with the action, like you shouldn't like your first thing shouldn't like be to delegate.
Mhm.
So if for an unfolding one, if everything's still going wrong and you've kind of done everything in your power, like
Yeah.
then is it okay to be like, okay, maybe I would call like notify the doctor, call RT, like notify the doctor.
Yes. Yes, like you have exhausted all of the resources that you can do. And you can say call the doctor at any time. That just shouldn't be your
Yeah.
only tool. Yes. Especially don't do that so early that you're like, I'm just going to let everybody do my job. You know what I mean? Now, as a new nurse, it's totally acceptable. If you don't know, you can always say, I'm not sure what to do. Here's what I would try to intervene with first. But I would always ask so-and-so expert or a charge nurse or whatever. Because that's a safe thing to do, right? You're safety conscious. I'm not encouraging you to be, to put your ego at the center of this and think you have to do everything. I'm just encouraging you to do what's the most safe for your patient. That's really what I'm looking for. Or
Yeah.
maybe looking for.
Yeah. Well, in nursing, it's a team sport. You're never going to be by yourself. And, you know, I would rather have a nurse who is willing to call for help, especially when you have a situation like this that could ultimately end up in a code. If the interventions aren't working, you need to have a team in there because you're not going to be able to run that code by yourself, nor should you attempt to. So having your resources there and knowing when to delegate, but also realizing that you are the primary nurse over that patient and that you have a responsibility. Because what I don't want to see is a nurse walking away from that and saying to the charge nurse, okay, it's yours now, and I'm gonna go grab supplies. Because, you know, I don't know what to do. It's a good learning experience for you to be able to do that, but also to be able to stay with your patient because you're going to be the one who's reporting those values and what's been going on in the past to that doctor or to the people who are coming in if this were to become a code. You know, the charge nurse isn't going to be able to say that. The other nurses who are coming in to help you aren't going to be able to say that. You were the only one who could talk about what has happened during your shift and to be able to provide the best level of care for that patient.
And I will say, Courtney, too, I'm glad you asked that because if at some point you don't ask for help from someone, that is also a red flag as well. So
Yes.
make sure that you do.
Yes.
We're not saying don't ask for help. We're just saying make sure that you're doing it in a timely way where you're not just abandoning your so, okay. Are we good on time?
Yeah, so we can take a break and come back at 12:10, and then we'll start on the next one. All right?
Who would like to go first? I'm just here when we come back.
Yeah. Okay, I'll go first.
Get the one with the long word. It's up to you. You want the long one?
Okay. I think Julie's coming up first. Is everybody back? I guess if you're not here, you would be.
It's okay, Julie.
Oh, do you all do something?
No, we already did that through our other interview practice.
Okay.
Right now, we just go to the table.
Okay.
Hello.
Hi.
I'm Julie.
Julie, so nice to
Nice
meet
to
you.
meet
I would
you.
shake your hand, but since
Yes.
we're in the Okay. So before we get started with Julie, does anyone have any questions? So like I said, try to follow afterwards we'll debrief. And also, I just want to reemphasize again that even though these are pediatric clinical scenarios, that the strategies that we're using should be applicable to whatever kind of job that you're applying for. Okay? Are you ready?
Before we begin, is it okay if I take notes throughout this?
Yes.
Absolutely.
Okay. All right, Julie. So, you are working on an inpatient pediatric unit and are admitting a 4-year-old boy who had a seizure with respiratory distress. Currently, his heart rate is 130 breaths per minute, a blood pressure of 98/62, respiratory rate of 8 per minute with an SpO2 reading of 80%. Tell me how you would proceed.
First, what resources are available to me, and I'm sorry.
No, you're right.
Okay, what resources are available, and is there a section? Am I in a regular unit?
You are in a regular unit and everything's available to you.
Okay, wonderful. So first, his O2 saturation is a bit low, so I would go ahead and put the oxygen on him
Okay, perfect.
as orders permit. Then I would continue with my assessment, kind of seeing visually whether he's having retractions, what kind of breathing, sort of breathing, is he crying? And then if the caregiver is with him, maybe ask some questions as well on how his condition has changed upon arrival to the hospital, what he looked like before they left their home, any significant changes within those time periods.
Sure.
And then I think I would go ahead and go into a focused assessment.
Okay.
Assess again his work of breathing, are the vital signs updated?
Yeah.
So those are the most recent vital signs?
Yes.
Okay, so after giving that oxygen, then I would probably reassess his oxygen saturation, his respiratory rate, if he's having retractions and other signs, other physical signs of increased rate of breathing. And
He has some mild retractions, but he's actually kind of lethargic right now.
okay, because he's lethargic, I guess I would go into asking the signs and symptoms, if he's allergic to anything, if there's any new exposures at home, asking mom or dad or the caregiver if there are siblings at home.
So he's lethargic, high fever for about 24 hours before. He doesn't have any allergies. He hasn't taken any medications recently.
Okay, so he has a high fever. And he had a seizure, so I would ask for a history upon birth or any congenital anomalies.
Just a history of seizure.
A history of seizures, okay. I think at this time I would probably go and ask the charge nurse for help, as I'm unsure of how to proceed in this situation, and probably call in the respiratory therapist if he continues to have the increased work of breathing and he's still at a low oxygen saturation.
Okay. All right. The end for now. How do you feel?
I feel really nervous. I was trying to go through the checklist, and I was like, wait, I know this, and this, but I don't remember what to use and what else I'm supposed to ask. So
I have to say, you appear very confident.
Yeah.
I never would have known that
Yeah.
you were nervous.
Yeah.
So kudos to you on that.
Yeah, sure. So for those of you following, she doesn't have her notes in front of her, and y'all do. So how do you feel watching it? You probably felt just fine because you're sitting there. So, tell me a little bit about what you experienced listening and watching all of that.
Well, just hearing Julie, her tone sounded very relaxed and not panicky, non-urgent. So that kind of indicates to me that if she ever had this situation, that's exactly what she would do. She wouldn't panic. And I could see her trying to think through what she would do. So even if she missed some parts, it's still obvious that she was trying to prioritize.
Absolutely. Okay, what else? Nothing else. Okay, cool. So, Now this is hard because you didn't get to do the prep that we talked about, right? So Julie's obviously interviewing for a pediatric position, right? The one glaring thing here was the intervention and default to action piece, because 8 breaths per minute is pretty low for a pediatric patient, right? So if we had given Julie an opportunity to prepare, she probably would have picked up on that. So if you guys had been in this seat and you did have time to prepare, the priority would be what? Her respiratory, right? Which she picked up on that, okay, something's not right with her respiratory assessment. They're tachypnic, their breathing is a little bit off, so she knew to do that. But if you guys had an opportunity to say, like, look at normal vital signs and something, that should have triggered you for a default to action. And what would your default to action be?
Whenever like you're answering that, or like whenever you're going through the steps, like, but like if you're saying, oh yeah, I would put them on oxygen, like would you specify like I would put them like on a non-breather, I would give them a simple face mask, and like would you say like what type of flow you would give, like depending on the mask, like would that be?
If you know that information, use it.
Okay.
Does that make sense? So Julie did the right thing. So she said, I asked her, tell me how you would proceed. She said, I'm going to go ahead and put oxygen on this patient. So do you see how she addressed the question right away and then went back and did her assessment? I thought that was perfect. Now, 8 breaths per minute, I probably would have recommended going ahead and bagging them, because obviously that's why they're statting so low, is that the respiratory rate isn't high enough. So that was perfect.
Great job.
Yes.
I have a question. You guys are talking about seizures. Would you like, are you looking for seizure precautions as well?
You could, but that's not the priority. Because did you notice how it was kind of like a distractor? Okay, they had a seizure, but what's really the most important right now?
Because I didn't know if you're like supposed to like address like, okay, they have seizures. Like it's not the priority, but like they should still have seizure precautions kind of thing. Or like, I don't know. I was just like looking at them like, how does that play in?
Yeah. So seizures, for sure, address it if you remember to do that. But even me as the interviewer, I just kind of forgot about this. Did you forget about the seizures? Because right now, I was concentrating on they have high respirations, they need oxygen, right? They probably need to be back at this point. So prioritization is like key to every scenario you're probably going to be asked. Yes?
Do you kind of just like end there too? Because I'm like wondering where you stop with that answer. Like,
Yeah.
how did you proceed, but like where do you stop?
I wasn't sure how much to keep going. That's why I kind of kept asking, like, oh, there's the seizure, and then
Yeah.
the history. Is that,
Yeah.
That's why I was also honestly unsure, like, was that pertinent? Like, should I have gone more into that? But you said it was a history, so then I
Yeah.
was like, okay.
Right.
Not
And
as-
when all I asked was tell me how you would proceed, right? You could have stopped, I'm just going to give them oxygen
Okay.
because this is bad. But it also showed me that you were thinking through your assessment. What else could you look for? Because you're not just going to, you're going to want to incorporate an assessment at some point to make sure you cover all your bases, right? And I thought it was great that you entered, like, okay, at this point I think I would notify my charge nurse. One thing too is that if you are asking different pieces of an assessment, you can also gauge whether your interviewer is going to offer it to you. So I didn't really give you, I didn't really answer, okay, I would look for this. And you didn't give me an opportunity to answer because I would have given you more information actually. So if you had asked me, what is their airway like? What is their breathing like? Can you tell me a little bit about their circulation? And if you can gauge that they do have that information, keep asking those questions. But if it's apparent that they just want you to list what you would look for and they're not, it kind of looks like they're making an answer up on the spot, they probably don't have that information. And you either answered their question or they're still waiting for you to perform an action. Does that make sense? Okay. Great job, Julie. Thank you. So scary, right? Do you have anything else to say?
The other thing, a lot of y'all are talking about being nervous, and I just want to tell you from a manager perspective, when I have new or nursing graduates come and interview with me, I know that you're nervous, and I can tell. And so, and most managers, know what's coming up, and we're not trying to intimidate you. We know that we're going to be doing a lot of teaching. We do get hired to our facility or wherever you may be, and so I really encourage you. I know it's hard to try and relax, but to really do that, because we want to engage in a conversation with you and go through and see what your critical thinking skills are. But don't be afraid to ask questions and to try and get a little bit more comfortable, because again, I'm not expecting you to give me the same answer as a nurse who's been a nurse for 10 years, right? I know that you're coming right out of school and that you are thinking more of a checklist mentality, and that's okay. Again, I'm looking, when I'm looking at a candidate, again, the fact that you're so confident and that you seem very poised and calm, those are really important things to me. Because where I would start to get a little cautious is if you're starting to panic,
Yeah. If you panic and then you can't recover, I think is a huge.
Correct.
Yes.
Sorry, so just to recap, I guess, so when you're asking those ABC questions, would you prefer, like, I would assess his airway and see his work of breathing, or would you prefer, like, okay, so I would go ahead and assess the airway, and then asking you, what is his airway like? So is there, like, a preference, or?
No, it's kind of, sometimes they're going to be very clear about, tell me what specifics you're going to ask in your assessment. And sometimes it's so open-ended like that, you don't know if there's more information hiding behind that question. Do you know what I mean? So it's totally appropriate to say, can I ask about A, B, C, D, E, or whatever. And if it's like, well, that's not really important right now, or it's very easy to kind of tell what the direction, if there's going to be a direction. Yeah. Are you ready, Courtney? Does anyone else have any questions or comments? No. That's for all of you. Okay, Courtney. You are signing on to your shift and are assigned to 3 pediatric patients. In report, you receive the following concerning information about each patient. So patient 1 is an 8-year-old with a known history of type 1 diabetes mellitus. The current blood sugar is 250 milligrams per deciliter postprandial. They're complaining of abdominal. Patient 2 is a 6-month-old female admitted for respiratory syncytial virus, increased work of breathing overnight on 2 liters nasal cannula and retractions. The range of SpO2 during vital sign checks every 4 hours were anywhere from 89 to 94% last night. Your third patient is a 10-year-old male with a diagnosis of asthma. They're currently on 5 liters face masks with scheduled nebulizers every 30 hours. Their vital signs are stable. Who would you see first?
Just from Zoom initial kind of debrief of each patient, I'd probably go to the one who had the retractions, the 6-year-old female, just because with the retractions and her oxygen isn't super stable, so I feel like her priority with like the ABCs and airway breathing, like that is the priority of all these.
Hers was, sorry, Julie, that was a little closer. That's it. Because you answered the question, right? All I asked was, who would you see first?
Yeah.
And I thought it was great that you followed it up with information about why. So how do you feel?
Oh, I mean,
I know, more drama, sorry.
I don't know.
Maybe switch those.
I guess if it were to have continued,
Yeah.
something that I was kind of curious about was like in the last treatment, like the nebulizer treatment with the asthma kit had.
Yeah?
Kind of just going off the ABCs, but like
Yeah.
because this O2 wasn't stable.
Yes. Yeah, and that's totally appropriate. You didn't need that information, did you?
No.
Because I said vital signs are stable for their kid.
Yeah.
So, what about you guys?
I just have a question.
Yes.
Does it matter if you address the other 2 and like why you wouldn't choose them as your priority?
You could, but I felt like the answer she gave me was sufficient. Do you know what I mean?
Yeah.
So I thought that was great because it was concise. So if you wanted to, but it's not necessary.
So you also prefer a concise answer rather than like an explanation of like, because I feel like this is like a priority, like, oh, I'm on shift, like this is my patient, this is what's going on, I'm gonna go in that room. Is that what y'all looking for? Okay.
Yeah, and I will say that it kind of simulates what goes on in real life, right? So we're really assessing what would go on in real life. This simulates what you like handoff, right? So you're getting a report. Okay, I need to figure out, who am I going to see first? This person looks like, that's what we were simulating just now, is I'm giving her a report, and she's going to go figure out which patient she needs to see. So I wanted to see, can she figure out quickly who she needs to go see right now? So, yeah.
Okay.
That was great.
Thank you.
Yeah. Okay, Tyler. Are you ready? 9-year-old female who is being admitted from the ED for respiratory distress. What would you include in your assessment?
So I would first walk into the room and I've already gotten a report from the ER nurse about what sort of important things. Was there any report from the ER nurse?
Nope, they just dropped the patient off.
Okay. And then I walk in, I take a look at the patient, and I would see from a distance, what's going on. Is she physically in distress, trouble breathing? What position she is in the bed? She's hunched over, trying to breathe a little bit more. Those kinds of things. Do I see anything like that when I walk in the room?
Yeah, they look pretty anxious. She's sitting up in bed. Her respiratory rate is increased. She's working really hard. Her lips are pink, and her nail beds look like they're all perfused.
So based off that information, I start working through the ABCD assessment. I start looking at checking her airway and seeing how she's breathing. Because obviously her positioning indicates she's having some respiratory distress currently. Is there any sort of stridor or any sort of breathing issues with hospitalization?
Yeah, so her airway's patent unobstructed. There's a little bit of nasal flaring. No abnormal upper airway sounds that are audible. Breathing, respiratory rate is actually 42 per minute. Diffuse bilateral expiratory wheezes and auscultation along expiratory phase. She's not moving air really well. Oxygen stats are 88% on room air. And that's all you asked for, right?
Yes. So was there any diagnosis made in the ER or just with acute respiratory distress?
Acute respiratory distress.
Okay, so based off the 88%, I would put up nasal cannula oxygen. I'll start about 2 liters to see if that handles the lowest of order breathing, because the respiratory rate is pretty high as well. So I would check and try and see if positioning has helped, change the positioning, start a little higher in the bed, and then I would reassess that. Once I got the oxygen on her, I would then further go to my assessment. Does the oxygen help?
Yeah,
Okay.
it increases to about 95.
And I've worked going through a more focused respiratory assessment,
Okay.
listening to anterior and posterior lung sounds, further evaluating the skin color, and the perfusion, the capillary rebuild to see if the issue is being adequately addressed by the nasal cannula and the change of position.
Okay.
Does the respiratory rate decrease?
A little, yes.
Okay.
Okay. So your patient's family members are at, what do you ask?
I'd ask them what have they already been told, what do they already know about the patient's condition.
She's not breathing really well.
Okay. I would explain to her them that who all is there?
The father.
Oh, just father. Okay. I would tell him that we put her on some oxygen to help her breathe a little bit better. She was breathing a little bit quickly, and it seems to be helping. And that we're going to go ahead and continue to monitor this. And if it continues to get worse, we're going to go ahead and call the doctor and see what we can do about changing orders to either increase the oxygen or try to provide some alternative respiratory treatments and contact respiratory.
Okay, perfect. Is there any other information you want to ask about right now?
Is there any sort of history of signs and symptoms from home that she exhibited before she came?
Yeah, actually, her mom has the full list, but I think she just has asthma. She's been to the ICU a couple of times for, I think, is it respiratory failure? We don't always get a chance to go and refill her meds.
Okay. Do you know what meds she takes?
Oh, I can't remember.
You can't remember? Okay. Is she usually pretty good at sticking to the meds at home?
I mean, we try our best.
Okay. When was the last time you remember she actually really taking meds?
Yesterday morning sometime.
Okay.
So, as you're taking history notes and your assessment, your patient isn't as responsive. Her respiratory rate is now 7 breaths per minute. What additional information do you need and what do you do?
First, I would go ahead and take a look at her oxygen saturation so we know that was going. We know her respiratory rate is 7, so that's immediately concerning to me. So I first get on the phone and get some help, or I call a rapid response at that point because we already know her condition is deteriorating from the interventions that we had when she came to the floor. And then work with the respiratory therapist when everybody comes and give a report to the doctor about what I've noticed, that her respiratory rate was good, decreasing the oxygen on the 2 liters nasal cannula, but now she's becoming unresponsive in the last, less responsive in the last couple of minutes, and is now requiring mask, ventilator mask.
Okay, Tyler, how do you feel?
Okay. It was good having been able to write things down. I kind of kept my mind focused on what I needed to do. bit better, but I think we're all right.
What about you?
You did amazing.
Yeah.
You did
Yeah.
so good.
Yeah.
You know what else I loved is that you informed the patient's family.
Yes.
Because so many times, especially as a new nurse, and I'm not blaming you for it, you're in that checklist mentality and you're only focused in on the patient. But you took the time, and this is what I have to coach so many new nurses on when they come in the floor, is that you're not just focused on that, but you also have to comfort the family members who may be, freaking out, and making sure that if you're not the person, because while this patient is starting to desat on you and, spiraling, that even if it's not you explaining to them, that you're able to assign that to someone else, because that family member needs to be in the know and needs to know what's going on, because they're over there, freaking out. So again, kudos to you for doing that, because not everyone, hones in on that portion too. But that's just as important as making sure that you're maintaining, this person's, status.
Yeah, honestly, I thought it added that little flair
Yeah.
that would have set you apart,
Yeah.
because all I was looking for was that huge bag masturbation.
Yeah.
Clinically, I'm like, okay, he knows what he's going to do.
Seriously, I
He knows
would
what
hire
he's
you
gonna
for
call.
that.
Yeah, same. Yeah, I was like, okay, that's perfect. Customer experience,
Yeah.
values for sure. I thought that was interesting that you assessed what my knowledge base was, so I felt like I was acting a little. But no, that's great.
Yeah.
You should feel very proud of yourself.
Yeah,
So
thank you.
good. And also, you kind of went last and got to apply and take notes. So that was
Yeah,
good.
yeah, that's
Yeah.
something.
Yeah, kudos to you, ladies. over
Any
there.
tips or anything I could have done better?
Just sit up a little bit.
Okay.
Yeah. I think that was the only thing.
And feel free to use, I could tell you were trying to concentrate on it and not get distracted. And I think that's a good tool. I mean, if that's what helps you to keep focused. Because again, you were asking questions and you weren't fazed by the fact that she was going off in a different direction, because that will be a family member.
Yeah.
People say to you, I don't know, and I don't know what the medication's called. And so you may not always get the best amount of information
Yeah.
from families, so you kind of have to, just run with it.
Yeah.
But I thought that you handled it very well,
Right.
because that's a very anxiety-provoking.
Yeah, and I will say, feel free to slow down just a little bit too, because I feel like that would even, it's like your answers instill that confidence, but too, I don't know if maybe you were a little nervous, but this is just extra stuff. I thought you did great, so yeah,
Thank you.
great job. Yeah. So we have about 10 minutes. I'm gonna go ahead and skip this. Okay, what questions do you guys have now? Yes, Kadeja.
What if there was a situation, like these were all like respiratory issues,
Yes.
but what if the situation is something like, me and Tyler were talking about this earlier, if it was like a pressure ulcer or something like that,
Yeah.
that has nothing to really do with like breathing, do you still like address like, is their airway okay, is their breathing okay?
Yeah, so in that situation, if you have a pressure injury, what are you most concerned about? Infection, right? So it's important to go back to there. So you're still going to want to gather more information. They're likely not just going to ask about a pressure injury, right? And if they don't give you much information about that, then that's your job to go back and gather more information. Does that make sense? And hopefully that will narrow down what they're asking of you.
Okay.
Because it might come out that, okay, they're infectious, and then maybe they're breathing a little bit harder because they're febrile. Does that make sense?
Yeah. I see what you're
So,
saying.
yeah. I really did mean it. If you're not sure, just go back. You know what I mean? It's okay to use it as a circle. Yes.
Is it appropriate to ask for medical diagnoses? Because I know Tyler asked it, but I also know that in nursing we're both more focused on nursing implications. So is that something that's okay to ask?
It is okay to ask anything, really, but sometimes just know that they might not give it to you. Yeah. Anything else? Okay, and I guess find us on LinkedIn. You already know what our pictures look like. I feel like I need to change. And then lastly, Amy had mentioned this earlier, but we're actually starting a podcast on behalf of the Texas Nurses Association. We really do love nursing, if you couldn't tell. Like, we are super, super passionate about it, and a part of that is also, getting to share stories of Texas nurses and all the incredible things that we all get to do, that you get to do, and don't discount that just because you're a student, we don't want to hear about you all. We are hoping to build this and have a little bit of a following, so we encourage you to join TNA at some point. Follow us, and it's called Nurse Life, so hopefully we'll have some marketing out when we do our first episode. And actually, we do have a couple of people from this class who are going to be joining us tomorrow. So this is kind of our call call for you all. If you're interested in getting interviewed just for your perspective on nursing, what you want your career to really look like, what nursing is going to look like in this current landscape, and what it might mean to you, because you guys are entering nursing in a completely unique time. It's different than even when we graduated, almost a decade ago. So we're interested to see what your career paths are really going to look like and what you're actually interested in and what things you'd like to change about nursing. So if that sounds interesting to you and you'd like to share some of your ideas with us, let us know. Come talk to us after class. We'll give you information on how to come and join that session. We're just looking for about 1 or 2 more people. And then we'll also be providing free food afterwards. So if anything, you'll get a free meal. So, okay.
And just to echo, what Donica said, we're very excited about this, and we really are focusing on, especially nurses within, nursing students, nurses who are still at the bedside. We want to get those stories and those perspectives, because truly, over the last 5 to 10 years, nursing has changed immensely, and we expect for it to do the same in the next 10 years. And really focus on the fact that, nursing doesn't have to mean that once you graduate from here that you're going straight to the bedside, that maybe you're going into informatics, maybe that looks a little different. And that's a very different mentality from that traditional mindset of, oh, we graduated with a BSN, and now we go work as a staff nurse in a hospital. There's so many opportunities for you right outside nursing school. Just like if you were to get a business degree, it doesn't mean that you're going to a Fortune 500 company right off the bat. You may go somewhere else. And so it's exciting to see that nursing is starting to develop these different paths, and it's becoming more acceptable. And that's what we're really trying to explore, is showing how today's nurse is living, what they're doing, and what they're doing in the community. That's not just taking care of patients at the bedside, that traditional look and feel of nursing, but what more are we doing? What leadership roles are we taking part of? What are your passions? What are you getting involved in outside of your work or outside of school? And really highlighting those to really add some breadth to what people typically see in nursing, or what they expect of nurses.
Well, thank you so much, Donica and Amy. Please give it